You have a variety of sleep disorders, but in this particular section, we are only going to discuss on the obstructive sleep apnea, central sleep apnea, and probably Pickwickian syndrome. Only these three components we'll be seeing. The remainder of the sleep disorders we can discuss in the central nervous system. Okay. First, what do you mean by an obstructive sleep apnea? Before knowing what is an OSA, we have to know the certain terminologies. Like for example, you have to know what are the definitions of airflow limitation. There are various definitions of airflow limitation. So what are some of the terminologies? Terminology number one, you have something called an apnea, which means cessation of airflow or stoppage of airflow, complete stoppage of airflow for at least 10 seconds. So certain textbooks give a definition for that also, where there will be more than 90% decrease in the airflow in the respiratory tract. So, but anyway, in general, you can remember that stoppage of airflow for at least more than 10 seconds is what we define as apnea. Second, hypopnea. Hypopnea means it's not apnea, it's not normal airflow also, it's somewhere in between. So, which means more than or equal to 50% cessation of airflow, more than or equal to 50% reduction in the airflow, but not complete cessation. It's more than or equal to 50%. That's what we refer to as hypopnea for more than or equal to 10 seconds. Number 3, you have something called a RERA. That's called respiratory effort related arousal. Respiratory effort related arousal. So what do you mean by RERA? So there will be a huge change in the airflow, but will not fit into the category of either your apnea, nor it will not fit in the category of hypopnea, but it will be associated with an arousal. That's called RERA. So which means it will be a large changes in the airflow, but will not come under the apnea definition as well as the hypopnea definition, but significant changes in the airflow will happen. Plus, it will be associated with the arousal of the patient also. So this is what we refer to as apnea, hypopnea and RERA. These are the definitions. In that, the most important are the apnea and the hypopnea definition that are very regularly asked in exam. Fine. So what are the indices based on this apnea, hypopnea and RERA? Based on these, you can give some indices also. The first index is the apnea hypopnea index. That's called AHI, which means what you're going to calculate is the number of apnea and the number of hypopneas per hour. So which means the total number of apneas and the total number of hypopneas that the patient is going to get in an hour. Which means how they really calculate is they take the entire sleep's apnea and hypopnea, total number of apneas and hypopneic episodes, and they will take the total duration of sleep and they calculate the total number of apnea and hypopneas divided by the total duration of the sleep. You are going to get the number of apnea and hypopnea per hour. In turn, it is the AHI, apnea hypopnea index. Number 2, you have something called a respiratory disturbance index. That's called RDI. This is even, not so popular in the current treatment and management areas, but still, let us know what is RDI, respiratory disturbance index, where it will be calculating apnea, hypopnea. At the same time, it will be calculating the number of RERAs also per hour. So all these three will be calculated. So that is what we refer to as respiratory disturbance index. So these are the indices that you are going to use. And there are two classic disorders that you have to know. One is the OSA and second is the CSA, central sleep apnea. In both this condition, there will be decline in the airflow, decline or stoppage of the airflow in the respiratory tract will happen in both these conditions. But remember then, what is the difference between obstructive sleep apnea and a central sleep apnea? The major difference is whether respiratory effort is there or not. Even though in OSA you have a reduced airflow, definitely the patient will have an intact respiratory effort. In fact, during the time of apnea, they will have increased respiratory effort. That is because it is due to obstruction. But whereas central sleep apnea is due to problems in the respiratory drive. The patient don't have the drive itself, that's why they go for apnea, which means the patient will not have the respiratory effort. So this is the major difference between obstructive sleep apnea and central sleep apnea. Reduced airflow with effort for respiration is there, then it's an obstructive sleep apnea. reduced airflow with no effort at all for respiration, then it will come under central sleep apnea. This is the most important difference. Clear? Now let us move on to the core concepts of OSA. So what are the risk factors for developing OSA? The number one and the topmost risk factor is going to be the obesity. That's going to be the most important risk factor. Apart from that, your male sex, black race, these are naturally prone to OSA, these patients. Then a lot of structural abnormalities in your oral cavity or the nasopharyngeal area that may predispose to OSA. For example, tonsillar hypertrophy or hyperplasia is a very important risk factor, including adenoids also. Adenoids also is a very important risk factor for childhood OSA. Then DNS, deviated nasal septum, uvular enlargement, enlarged uvula, then acromegaly causing macroglossia or any other condition causing tongue enlargement, macroglossia or enlarged soft palate, and patients who are having nasal polyps. At the same time, patients are having overbite with small chin and pharyngeal hypertrophy. Overbite means it's something like this. Underbite means inside. So overbite especially has a high risk of developing obstructive sleep apnea, especially with those have with small chin and pharyngeal hypertrophy. These are some of the anatomical and structural risk factors that the patient may have that predisposes them to increased risk of developing obstructive sleep apnea. Then usage of alcohol, because alcohol relaxes the pharyngeal muscles and tongue may fall back causing obstruction. So alcohol use regularly in the night again is a very important risk factor for developing obstructive sleep apnea. Then use of sedatives, again same reason, relaxes the pharyngeal muscles and the tongue, so you might result in obstruction. Smoking, definitely risk factor, a well-known risk factor. And conditions like endocrine problems like hypothyroidism, acromegaly, amyloidosis, and a lot of other conditions also as a risk factor for developing obstructive sleep apnea. So these are some of the major risk factors that you have to know. But the topmost risk factor, as I told you, it's always the obesity that tends to be the maximum risk for developing and the most common risk and the most important risk for developing obstructive sleep apnea. Now let us see what are the pathophysiological aspects. The most important pathophysiological aspect is the apnea that happens during the obstruction time, and that is what is going to predispose to a lot of problems. So what are they? Let us see. Number one, this apnea will lead to microarousals, which means during the time of apnea, the patient struggles to breathe, and that time if he cannot breathe because of the obstruction, he will suddenly wake up for a very short period of time. This is called microarousal to correct the, like your abnormality, because only when they wake up, they can voluntarily put the tongue that is falling back in front. So that is the reason why that microarousal is important to relieve the apnea, but at the same time, this is going to cause problems also. This microarousal will cause excessive sympathetic activity, which can predispose to hypertension, which can in turn predispose to cardiovascular complications in the future. Next, this apnea is also associated with increased breathing effort, right? In obstructive sleep apnea. This can result in increased preload. Why increased preload? That is due to development of negative intrathoracic pressure, because when you take breath only, your negative intrathoracic pressure will be neutralized as per your physiology. But if there is an obstruction and you still put a breathing effort, only the pressure will decrease in intrathoracic cage, but you will not have any movement of air. So it just sucks up the blood from the great veins, resulting in increased preload. And that will again result in hypertension, because increased preload obviously will be associated with increased stroke volume according to Frank Stalling. So you are going to result in hypertension and further cardiovascular complications. And this apnea also lead to reduced ventilation. So reduced ventilation means you are going to result in a VQ mismatch, where the ratio will decrease. VQ ratio will decrease. Because of the VQ mismatch, you will go for hypoxia and hypoxemia. Hypoxia. Hypoxia has two effects. The most important effects is, you know very well, they're going to activate hypoxic pulmonary vasoconstriction. If it's for a long time, if it's chronic, then it can go for even pulmonary artery hypertension. Clear? So we clearly know that this is called type 3 pulmonary hypertension, that is due to lung disease causing the pulmonary hypertension. So this is type of pulmonary hypertension we have seen in the last video already. And over time, if it's still chronic pulmonary hypertension, this can go for carpulmonal and overt right ventricular failure. And this hypoxia also predisposes to the development of arrhythmias because of excessive sympathetic discharge. So a lot of, pathophysiological aspects are there to understand in a patient with the obstructive sleep apnea. Now, next thing what we can discuss is on the clinical features. So what could be the clinical features of OSA? Clinical features wise, the most important feature and the very common feature the patient's attenders complaint will be on the snoring, which tends to be extremely loud with periods of apneic episodes. All these things will be reported by the family members itself most of the time. The snoring will suddenly stop and that will be followed by a waking microarousal from the patient, that is to correct their abnormality, and then they go back to sleep and again they start snoring over a period of time. So this snoring is a very, very common complaint by the attenders. And many patients themselves will complain of a very important fact called EDS. EDS we know very well, it is excessive daytime sleepiness. That is because in the night, because of many apneas, if it's causing microarousal, they won't sleep at all properly in the night because of small arousal that is disturbing the sleep throughout the night. So they will have a severe excessive daytime sleepiness. And most of the patients, they will have how they have microarousals in the night. Similarly, they have micro sleeps. This is referred to as 30 seconds of sleep during when they are in a meeting, when they are in a public, or when they're even seeing a movie, they suddenly sleep for 30 seconds and they wake up again. So these are called as micro sleeps and very characteristic of OSA. That is suggestive of excessive daytime sleepiness. Especially in our community, it's characteristic of OSA, micro sleeps. Then you might end up, because of this, you might end up with a lot of complications. Very important complication we already discussed is hypertension. Remember, one of the important causes of resistant as well as secondary hypertension is OSA. Whenever the patient is not responding to your treatment, or whenever the patient is having a resistant hypertension, or whenever the patient is having secondary cause of hypertension, you have to think about OSA as a very, very important possibility. That might blunt your response to antihypertensives also. Then patient will have reduced cognition or reduced cognitive function because they are not sleeping in the night at all. How the brain will work in the morning. So they will have impaired attention. Their performances in the work as well as the school plays or studies or whatever it is, it's going to reduce a lot. So that's why it's a very important disorder to consider. And number 3, it increases the risk of RTS. Again, this is due to micro sleeps. While driving, they suddenly sleep for 10-20 seconds and that is very dangerous, you know that. So that is the reason for increased risk of road traffic accidents. Apart from that, they can result in depression because of poor sleep quality for a long and chronic period. And they can have reduced libido, and depression can lead to reduced libido, and reduced libido can lead to depression. Both are synonymous. That's why I'm writing together. And high risk of cardiac arrhythmias like atrial fibrillation. Cardiac arrhythmias is due to hypoxia, number 1. At the same time, it can be due to pulmonary hypertension also. At the same time, it is due to systemic hypertension also. All these features will contribute to the cardiac arrhythmias. And high grade risk for cardiovascular complications like MI, stroke, death. All these things is very high with OSA patients. Why? Because many risk factors are there. Obstructive sleep apnea, development of arrhythmias, systemic hypertension, and all these things, chronic hypoxia, all these things itself is going to be a very high risk factor for developing this cardiovascular complications like MI and stroke. And these patients are also prone for pulmonary hypertension and carpulmonal, as we have already discussed. So these are some of the complications of patients who are living with obstructive sleep apnea. That's why understanding this disorder is of paramount importance. And next is, what are the scalings? What are the scoring systems and the questionnaires that are available for assessing the OSA? Questionnaire. There are various questionnaires are there, all of which are asked in exams already. The first important questionnaire is Epworth Sleepiness Scale. That's called Epworth. SS stands for Sleepiness Scale, ESS. The important understanding about this Epworth Sleepiness Scale is very simple. that it is a scale for EDS, that is excessive daytime sleepiness, not specifically designed for OSA. Which means this scale you can use for narcolepsy patients also. It's just a scale of excessive daytime sleepiness. That's it. There will be a total of 8 questions in the questionnaire. Each question will have a score from 0 to 3. Each question will have a score of 0 to 3, which means the total score will be 0 to 24. This will be the score. Any score more than or equal to 9 means the patient is having a significant excessive daytime sleepiness. That's what it predicts. Score of more than or equal to 9 means the patient is having a significant excessive daytime sleepiness. Now, second one, what we are going to see is on the stop bank questionnaire. There are 2 questionnaires which are specially designed for OSA. One is called stop bank questionnaire, and next one we have something called a Berlin questionnaire. Berlin is a very complicated questionnaire, but these 2 questionnaires are specially designed only for OSA purpose, which means they are more special for OSA compared to the Epworth Sleepiness Scale. But Berlin is so complicated, so we are not going to talk about that. Only stop bank, we can talk about that. Stop bank is an acronym for 8 different type of features and 8 questions that are asked in this stop bank questionnaire. S stands for snoring, yes or no. T stands for whether the patient is having tiredness during the day, daytime tiredness. All are in yes or no format. And O stands for observation of apnea by the family members. Observation of apnea by some of the members of the family. And P stands for pressure, that is blood pressure. Blood pressure. And B stands for BMI more than 35, obesity. Then your A stands for age more than 50. And the N stands for neck circumference more than 40 centimeter. I can write here. Neck circumference more than 40 centimeter, that is 16 inches. G stands for gender. Gender, especially male gender. That's what you're asking about. So all these questions I told you are going to be in the yes or no format, which means answer to at least 3 questions if it's yes. At least if you are having answer yes or answer is yes to at least 3 questions. At least for 3 questions, if you are answering yes, then it indicates increased risk of developing OSA or a very high risk of developing OSA. These are the questionnaires. I strongly expect the stop bank questionnaire for the exams. Snoring, tiredness during sleep, observation of apnea by the family members, pressure, that is blood pressure, that is elevated, and your BMI more than 35, then your age more than 50, neck circumference more than 40 centimeter, or you can call it as 16 inches, or finally you have something called the gender, which is the male. So if out of 8 questions, if your answer for at least 3 questions is yes, which means the patient is going to have a very high risk of developing OSA. It's a very common question used in my OPD also. This is what I use instead of ESS. I actually use this, which is more easier to analyze the patients. And with this, we can move on to the investigations that are used in obstructive sleep apnea. What are the investigations you will use in obstructive sleep apnea? Let us see now. The 2 investigations that we commonly prefer for diagnosing obstructive sleep apnea, one is the PSG, that is the polysomnogram, and the second one is the HSAT, that's called home sleep apnea testing. So what are the advantages and what are the disadvantages of the PSG and home sleep apnea testing? This PSG is considered to be the gold standard for obstructive sleep apnea diagnosis. This is considered to be the gold standard for OSA diagnosis for various reasons. The important advantage of a polysomnogram is the fact that it doesn't only diagnose obstructive sleep apnea, it can diagnose a central sleep apnea also. It can diagnose other sleep disorders also, which means it's not only for OSA diagnosis. But the major disadvantage of this polysomnogram means it needs a sleep lab. You have to take the patient to the sleep lab. So patients who are highly morbid and comorbid, who are stuck to home, cannot be shifted to a sleep lab to do this testing. And you have 2 types of PSG. One is called a full night study, where you can keep the patient full night and study in the sleep lab, or you have something called a split night study, where only the first half of the sleep will be monitored. The second half the patient can go back home. So this is called a full night study versus a split night study. So where the patient needs to be in the sleep lab, if at all, you have to do a PSG. What is the best area where you can do a PSG? In patients who are having excessive daytime sleepiness, plus if you're having a negative home sleep apnea testing. So these patients are the best patient to be taken for a PSG, because it's a cumbersome procedure, complicated, but still in this patient there is no other option. Because this excessive daytime sleepiness in the presence of negative home sleep apnea testing may be due to other sleep related disorders also, which can be diagnosed only with the help of PSG. That's it. So what about the home sleep apnea testing? Home sleep apnea testing has a big advantage because it has a portable monitor, which means you can do this in home itself. You need not go to the sleep lab, which means you can avoid the movement into the sleep lab. Number one. Second is, it can be done in patients who are having high level of comorbidities. For example, a patient is having a lot of cardiac failure, respiratory failure and all. These patients cannot be transported. So these patients better is to do a home sleep apnea testing itself. And which is the best place? I told you this is the best indication for doing a PSG. Similarly, what is the best indication for doing a home sleep apnea testing? Especially in patients who are having very high pretest probability. Very high pretest probability for OSA. So which means this actually the test result depends on the pretest probability. So if you have a high pretest probability for OSA, again the positivity in HSAT rate will be very high. So that is why these patients are specially preferred. So these are the areas where you can do a PSG as well as a home sleep apnea testing. Now let us go and interpret the severity. So you have to see an index called apnea-hypopnea index, which is going to tell the severity of the apnea, especially OSA, which you are talking about. So first, if the AHI is less than 5, which means it is not an OSA at all. There is no OSA because less than 5 is normal. That's why. If it's 5 to 14 AHI per hour, so then you can call it as a mild obstructive sleep apnea. If it's 15 to 29 per hour, then you can call it as a moderate OSA. Then if the apnea-hypopnea index is more than 30 per hour, then you can call it as a severe OSA. Clear? So once you have graded the severity, let us see what could be the treatment of the OSA. Treatment of the OSA is very simple. First one is conservative, and second one is your positive airway therapy or positive airway pressure therapy, PAP. So what about the conservative therapy? The conservative therapies are also very, very important, especially the weight reduction. Obviously, you are going to achieve by diet and lifestyle modifications like exercise. And this weight reduction is such an integral part of OSA management because weight reduction itself has given a dramatic relief in a lot of patients. Because obesity is one of the most important and most common risk factor for developing obstructive sleep apnea. That's why this becomes a very crucial an important thing to treat a OSA patient. And some guidelines even tell bariatric surgeries to reduce the risk of getting a severe OSA in patients who are having moderate OSA. So all these things we are not going to discuss because they are controversial guidelines. But anyway, weight reduction has a huge impact. Please note that. And second one, you can also do other conservative managements like avoiding agents that predispose to development of OSA and pharyngeal relaxation. What are the agents? Most importantly, alcohol. So taking alcohol in the night should be strictly avoided. At the same time, patients who are taking sedatives like benzodiazepines to sleep in the night again should be strictly avoided because these agents relax the pharyngeal musculature and they increase the risk of developing OSA and they can worsen the OSA if the patient is already having the OSA. So avoid this. So these are the main strategies in conservative management. Apart from that, in positive airway pressure therapy, this is considered to be the gold standard for treating an OSA patient. And there are very different types of positive airway pressure therapy. The most commonly used being the CPAP. That's called a continuous positive airway pressure, the details of which we have seen in the ventilator section itself. Continuous positive airway therapy is the one that is preferred for OSA and it is the most commonly used method for treating a OSA patient. And next, you have other methods also that is not used typically for OSA, but few guidelines suggest it for OSA, but they are more used for other purposes, other disorders compared to OSA. Like you have BPAP. This is called a bi-level positive airway pressure. This is more useful for CSA than a OSA. even though they are used for OSA, but they are very useful for a central sleep apnea patient. Third one is APAP. This is called auto titrating positive airway pressure. Then you have a ASV. That's called adaptive servo ventilation. Adaptive servo ventilation. These are all are very new strategies of ventilation. But even though these have concrete data for treating in OSA and or CSA, but this APAP and ASV are still in the trial stage, which means they are still very naive to use in the regular practice, because some trials have told ASV even have a deleterious effect on the cardiac failure patients. So we are not very sure about what are the real benefits. So the trials are being done, and so await for the trial. So once the trials are updated, it will be updated in the future lectures of Dr. Dilip's MMS. So till that, now we'll just tell these are very controversial maneuvers. That's it. So let us see what are the differences between a CPAP and a BPAP. Remember, a CPAP can treat OSA, but it cannot treat a CSA. But on the other hand, the BPAP can treat a CSA as well as a OSA. But it's preferred for CSA, alright. But why? Why is this difference? We already saw a lot of things in the respiratory failure and ventilator section, but let us recap this once again, those who are seeing the OSA video for the first time. Let us put the zero pressure here. This is the atmospheric pressure, and how the normal inspiration and expiration works, a normal tidal breath works. So it's going to be something like this. This is going to be the normal respiration, where you have inspiration here, expiration here, inspiration here, expiration here. So this is how it's going to work. But how CPAP works is you are going to maintain a positive pressure. This positive pressure above the baseline or above the atmospheric pressure. So which means this is the atmospheric pressure. This positive pressure that you are maintaining above this atmospheric pressure is what we are going to call as the CPAP pressure. That's called a continuous positive airway pressure. Which means normally what you did is you have alternated your breath, that is inspiration expiration, around the atmospheric pressure at zero. But here, if you are using a CPAP, you are going to alternate your breath at the CPAP pressure. Now the CPAP becomes the new atmospheric pressure. So your breath will be alternating around the CPAP pressure, which means during expiration, your breath can reach a pressure of, suppose if the CPAP pressure is plus 5 centimeters of water. Now during inspiration and expiration, it will alternate. So during expiration, your pressure of the system might reach up to 6 to 7 centimeters of water, and during inspiration, it might reach up to maybe 4 centimeters of water because of the little decrease in the pressure that happens during the inspiration. So which means the breath will alter around the CPAP pressure. So why you are giving a positive pressure? Because you can see now the pressure of the system is always maintained in the positive range. During inspiration as well as during expiration, the net pressure in the airway system is always above the atmospheric pressure, which will help in opening up the airways. The idea of giving CPAP in an obstructive sleep apnea is to open up the airways that are collapsing near the pharynx and the upper airway. If it's collapsing, you are giving CPAP pressure to open up this airways so that you can produce the ventilation better, you can breathe better. That is the idea. So for a strict OSA purposes, your CPAP must be more than enough. Okay. But what about a BiPAP or a BPAP? BiPAP is actually a brand name, you should not use that, but let us use the original name, that is a BPAP, bi-level positive airway pressure. So what is BPAP? In a BPAP, the mechanism is completely different. So if you take, this is the atmospheric pressure, that is 0. In a BPAP, they will maintain a constant expiratory pressure, which means there will be a constant expiratory pressure. That's called EPAP. You can think this is like a CPAP, but actually it's not. It's separate. Let us see how it is different. It's an EPAP. It's expiratory positive airway pressure. At the same time, the patient will not be allowed to take a breath that reaches a pressure below the EPAP, which means even during inspiration, it is made sure that the pressure will not reach below the EPAP pressure, even during inspiration. Which means what you are typically doing is, you are trying to increase the pressure during inspiration rather than decreasing the pressure during inspiration. There in CPAP, the patient is taking a breath, that time the inspiratory pressure drops and it can reach below the CPAP pressure. But here it is made sure that the inspiration is also supported with a positive pressure. Clear? But here, the inspiration in CPAP is not supported with any kind of positive pressure, which means a constant pressure that is maintained in the system, where inspiration and expiration will alter in CPAP. But here, its expiratory pressure means below this pressure you cannot reach, and the inspiration is also pushed with a positive pressure. Clear? So which means they will have a separate pressure in the form of IPAP also. This is called as inspiratory positive airway pressure. That's called IPAP, which means the breath can happen only in this range, which means you can breathe only in this particular range, which means this will be the inspiration, this will be the expiration, this will be the inspiration, and this will be the expiration, this will be the inspiration, and this will be the expiration. The major difference between a CPAP and the BPAP is the fact that inspiration is also supported here with positive pressures. Clear? There in CPAP only the expiration is supported with positive pressures, but here the inspiration is also supported with positive pressures, and the pressure in the entire airway system can never go below the EPAP pressure. Whereas there during inspiration the pressure went below the CPAP pressure, but here it can never go below the EPAP pressure. And the main idea of this is the fact that this IPAP pressure will determine your tidal volume also. Will determine your tidal volume. How? Because we have the famous ventilator equation which we have discussed multiple times, that is peak inspiratory pressure is equal to flow times the resistance plus tidal volume by compliance. I told you, if you increase the pressure, your tidal volume is also going to increase, and vice versa. If you increase the tidal volume, your pressures also will increase. Very, very simple, isn't it? So, which means at a set IPAP, which means if I have a flow, and the resistance as constant, and the compliance as constant, definitely your pressures are directly proportional to the volume, which means the more and more I set the IPAP, more and more I am going to achieve the tidal volume. Less and less I set that IPAP, less and less I will be achieving the tidal volume. Which means this BPAP is especially useful for patients who are breathing at a low tidal volume. Clear? Especially for patients who are breathing at a low tidal volume, this BPAP is absolutely useful as a non-invasive form of ventilation, because it can deliver the set amount of tidal volume also by setting IPAP at a higher level. Suppose if I am breathing only 100 ml of tidal volume because of some neuromuscular paralysis in my diaphragm, this BPAP will increase the pressure so that my tidal volume will increase, because the pressure is proportional to volume in the positive pressure ventilation. So I can increase the tidal volume by setting higher IPAP. My tidal volume might increase from 100 ml previously to now maybe 300, 400 ml, which is normal for my body. Very simple. So this is a beautiful mechanism of how IPAP works. And second thing, but you can ask me one question, it increases the tidal volume only. So patients with low tidal volume, giving a BPAP and increasing the IPAP component of the BPAP will definitely increase the tidal volume to the normal range. There's no doubt about that. But what if the patient doesn't take breath at all? If I don't take breath at all, which means I'm having a central problem, which means if my respiratory rate itself is slow, still in those patients I can use BPAP or not? Yes, I can use a BPAP where I'll be using something called a BPAP with a backup respiratory rate. Backup respiratory rate. How it's going to work? You know, the BPAP mechanism is very simple. So this is going to be the EPAP and this is going to be the IPAP. So suppose if the patient is initiating a breath, let us assume the normally the patient can produce only this much tidal volume, but during inspiration, but this BPAP will take over and make sure that the patient reaches this much inspiratory positive pressure, because it has to push to that level. The system makes sure that, and the tidal volume will be delivered and the patient will come back from here. So this is the support given by the system here. So it makes sure that that particular positive pressure will be reached, which means that particular tidal volume will be reached for sure. And now, suppose what if, okay fine, so this is the patient's pressure that can be generated, so that much volume only can be reached. Now the system assists and reaches to the set pressure and make sure the tidal volume also will be delivered, because the set pressure is reached now and they will come back again. So these are all patient triggered breaths. You can see this is all patient related factors. But what if the patient doesn't breathe at all at this point? So now if you set a backup respiratory rate in the BPAP machine, they themselves will start delivering the breath, which means a backup respiratory rate is very important, especially during the times of apnea. Which means this can be used for patients with central problems also. That is why BPAP, I told you, it can be used for central sleep apnea. OSA obviously yes, because OSA definitely is producing a positive pressure in the system which will open up the airways. But still it is not that famous in OSA, but for CSA definitely yes. But for CSA you cannot use your continuous positive airway pressure because here it is not having any backup rate or it's not going to maintain any positive pressure. Inspiratory positive airway pressure is not there and the entire system is dependent on the patient's own breath. Which means whatever tidal volume the patient produces, it's dependent on the patient only. It's not dependent on the machine. Whatever respiratory rate is produced, again it is dependent on the patient only. So the machine is not going to change any of this. Respiratory rate will not be changed. Tidal volume also will not be changed with the CPAP. That's why it's only used for opening up the airways. At the same time, it cannot be used for patients who are having a type 2 respiratory failure, alveolar hypoventilation or a central problem. You cannot use this. But BPAP on the other hand, it can modify the tidal volume also. It can modify the respirator also by setting a backup respiratory rate. Which means it makes sure the set pressure is reached, which means the set tidal volume also will be reached. It also makes sure the set respiratory rate also will be reached as a minimum. So that is why it is used for type 2 respiratory failure, and that is also the reason why it can be used for patients with central sleep apnea also, where in both these conditions CPAP cannot be used. But remember, BPAP can be used for type 1 respiratory failure also and for OSA patients also, but CPAP cannot be used for these purposes. Clear? Fine. Adaptive servo ventilation is a modification of a BPAP only, but it's something little different. It's an intelligent system, but it works in a different way. Let us see how it works when we are going to deal with the central sleep apnea. That time we will discuss in detail about the adaptive servo ventilation. But right now, we have known about how these different positive airway pressure systems are working. Basic systems, CPAP and BPAP. And what are the indications for treatment? What are the indications of positive airway pressure therapy? Indications of PAP in obstructive sleep apnea. Okay, point number one. You have two variety of guidelines. One is called American Association of Sleep Medicine Guidelines and second one is British Thoracic Society Guidelines. During our days, we used to study the BTS guidelines. Now ASM guidelines are getting famous, but whatever may be the case, the idea is the same. I'll tell you what is the idea behind these guidelines, then you will laugh at yourself because the guidelines are something which is just a guide for all of us and the guidelines may differ according to your local practice and the type of patients you are seeing. You should not take these guidelines as imposition and you have to impose yourself and you have to follow these guidelines for sure. It's never like that. Guidelines are only to guide. And always there is something called intelligence within us for that which can change. Even the guidelines we can change based on our practice with the local population. So be a smart clinician rather than a guideline-based clinician. So that is not going to work in the practice. So what is the ASM telling? American Association of Sleep Medicine is telling all OSA patients can take any degree, mild, moderate, severe. If any patient with OSA, you can take positive airway pressure therapy, no problem. But as BTS guidelines are telling, in patients with AHI more than or equal to 15, irrespective of the symptoms, which means any patient with a moderate to severe OSA, irrespective of whether they are symptomatic or not, you have to give positive airway pressure therapy. Or if a patient is having AHI in the range of 5 to 14, which means patients who are having a mild OSA, they should have excessive daytime sleepiness or they should have some symptoms like reduced cognition or excessive daytime sleepiness, which means in a mild OSA, only if the patient is symptomatic, they will give positive airway pressure therapy. You know what is the difference between these two guidelines? Why these two guidelines are giving different data? If I tell you the real reason, you will definitely laugh at it. It's based on the insurance policies. In USA, the insurance companies are ready to provide this CPAP machines and BPAP machines even for patients who are having any degree of OSA, even mild OSA. But in British, in UK, the NHS, because it's more cost concerning, they are giving this CPAP and BPAP machine, that's positive airway therapy machines, only for patients who is having a moderate to severe OSA, or if the patient is having a mild OSA who is symptomatic. They are not giving for asymptomatic mild OSA patients, they are only giving weight reduction and conservative therapy. That is for cost cutting, based on the local insurance policies. So that is why I am telling you, don't take these guidelines very seriously. Many times the guidelines may be framed just based on the local policies. So don't be very guideline friendly. Like it's not going to help you anytime. Clear? So one problem with this positive airway pressure therapy, I told you the indications of positive airway pressure therapy, but if the patient is okay, financially okay, you can follow this ASM guidelines because this is the gold standard. Positive airway pressure therapy is the gold standard for OSA treatment. The patient is compliant with what you are telling, and the patient has a good rapport with you, and this patient is reasonably rich in your well-to-do in your practice, then it's fine. Or if it's available in your center very easily, then you can easily provide this OSA machines for use in these patients. Clear. What is the one important problem that you will develop with positive airway pressure? There is one important thing called treatment emergent CSA. Treatment emergent CSA. This is a very funny thing, which means the patient will be having OSA. You are giving a CPAP or a BPAP. But you know what we will prefer? We are going to prefer CPAP only. If it's OSA, there's no need for a BPAP in these patients unless until they're having a central component also. They might end up with a CSA. Almost 10% of the patients who's receiving CPAP or BPAP after being diagnosed as OSA can get a central sleep apnea. 10% of the patients. Why this is happening? And the risk factors for developing this CSA after given with positive airway pressure in a patient with OSA is number one, especially patients who are having severe OSA. Severe OSA patients have more risk of developing treatment emergent CSA than other patients. And second, if you are using a BPAP, the risk is more compared to CPAP. This is astonishing actually. BPAP is used as one of the treatment of CSA, and use of BPAP is associated with the more risk of developing a CSA in a patient with a OSA. Something, like really confusing, isn't it? So this is what the trials are telling. BPAP use is associated with more risk of treatment emergent CSA in OSA patient, and severe OSA itself is a risk factor of developing treatment emergent CSA in a patient who is having OSA. Clear? So previously this CSA was called as complex OSAs or complex sleep apnea syndrome. That's what they call it. This was the old name for this CSA. But right now, the central sleep apnea that develops after giving positive airway pressure therapy for OSA is typically referred to as treatment emergent CSA. Clear? That is thought to be due to reduction in the respiratory drive because of loss of CO2. Remember, these OSA patients typically tend to have a high CO2 to an extent at least. Hypercarbia is a very important feature, and that is the one that causes the respiratory drive in these patients, and that all this arousals, respiratory drive and all these things is because of the excessive CO2. And they'll be always used to that high CO2 in the brain. That is maintaining the respiratory drive in these patients. By giving a positive airway therapy, positive airway pressure, suddenly you normalize or decrease the CO2 from the usual level they tend to have. So that is the one that is going to reduce the respiratory drive, and that is what is thought to result in the central sleep apnea in this patient. That's called a treatment emergent CSA. This is the mechanism that is due to loss of CO2 related respiratory drive. That is what is thought to be the reason, and many of the patients, as much as 90 to 95% of the patients will recover over time because their CO2 will set to a new value now in their own body. So they will adapt to the new CO2 values, and their respiratory drive will once again set to a lower value of the CO2. What they are adapting with this positive airway pressure. So no need to worry much. Clear? So this is what we refer to as something called a treatment emergent CSA, which is a very important thing in exams to know. Suppose if they tell, after starting with the positive airway pressure therapy, if the patient is having recurrent apnea episodes, what is the possibility? Your answer must be treatment emergent CSA, which is more common with a BPAP than a CPAP, and patients who are having severe OSA than a patient who is having a mild or moderate OSA. Clear? So this is a very important treatment. Next thing what you have to know is, what are the other treatment options for patients who are having obstructive sleep apnea? Other treatment options include, number one, oral appliances. Remember, sometimes patient may not be willing to use this CPAP devices or any of the positive airway pressure techniques. In those patients only you have to try these other treatment options. You should not try for patients who are using CPAP or who are compliant with CPAP. Only for patients who are non-compliant with CPAP and your positive airway pressure therapy, or patients who cannot use these therapies, for them only you have to use the oral appliances and other treatment options which I am telling. Oral appliances, a lot of oral appliances are there. For example, you have mandibular advancement devices. These are called mandibular advancement devices or mandibular advancement splints. Then you also have this tongue retaining devices. I don't know if the patient is not willing for this CPAP therapy, then how will he be willing for oral appliances? I have no idea, but still, that's what the guidelines are telling. But these are less effective compared to the positive airway pressure therapy. Second one, you can do a surgery. Surgery, again, it is very, very controversial. Only patients who are having some anatomical problems like large tongue, then large palate, then large uvula. These anatomical abnormalities may respond a little bit, but overall the surgery has a very poor significance in the management of the OSA. One of the important surgeries is called UPPP, that's called uvulopalato-pharyngoplasty. Uvulopalato-pharyngoplasty. So these are very, very limited benefit. At the same time, remember, oral appliances will be effective only for mild to moderate OSA. It will never be effective for severe OSA patients where only positive airway pressure therapy will be useful. Number 3, one experimental treatment is going on that is called hypoglossal nerve stimulation. This is currently experimental and it is showing a good result actually, but it is not yet in the practice, especially in India. It might come in the future. So let me show you some of the images that you want to know. So this is the typical CPAP mask that you have. It's difficult only where the patient has to wear this mask in the face and sleep in the night. And yes, but even though initially it is difficult, once they become compliant, they have a lot of better functional outcomes as well as very good outcomes in the cardiovascular status, like reduction in the arrhythmias, reduction in the cardiovascular mortality, like MI, stroke and all, good cognitive scores in the morning because they sleep well in the night. They don't have excessive daytime sleepiness, RTS reduce, hypertension reduce. Lot of advantages are there for CPAP. So that's why even though it looks difficult, but still once they become compliant in the early phase, if you counsel them better, it might be very, very useful and helpful. You can see this is the mandibular advancement device or a mandibular advancement splint that you're using. And again, remember these devices will be useful only for patients who are having mild to moderate OSA plus who have declined the CPAP therapy. Otherwise, this should not be used. This is tongue retainer. This is a tongue retaining device. And this technique is what we refer to as the hypoglossal nerve stimulation. You can see the stimulating electrode where it will stimulate the hypoglossal nerve so that the tongue doesn't fall back at all. It will keep the tongue in place. That's called hypoglossal nerve stimulation. So these are the important images that you have to know with regards to the obstructive sleep apnea. Then we'll move on to the central sleep apnea. The most common form of central sleep apnea, the most important type of central sleep apnea is going to be your Cheyne-Stokes respiration. So common. Cheyne-Stokes respiration. You know what happens in Cheyne-Stokes respiration. We have seen already this particular fact in the regulation of respiration chapter itself in the basics, where you will have a crescendo decrescendo pattern of apnea, hypopnea, hyperpnea episodes. That will be in a crescendo decrescendo pattern. For example, initially the breath volume will keep increasing. This is what we called as crescendo pattern, where initially they will have a hypopnea, then subsequently they will go for a hyperpnea. Later on, they will have a decrescendo pattern where they will have following hypopnea and then finally they will end up with a apneic episode and the cycle will continue, which means they will have a typical duration of breathing episodes which alternate with apneic episodes. So they'll have duration of breathing episodes which will be alternating again with the crescendo decrescendo pattern, and they will have in between some apneic episodes, and this will have some characteristic time period for a particular individual. So this is what we refer to as a Cheyne-Stokes breathing. If you analyze why this Cheyne-Stokes breathing is happening, it's due to one important basic pathophysiology, that is the exaggerated response to CO2 by the brain. Exaggerated respiratory response to CO2 levels. This is the pathophysiology, and this exaggerated response to CO2 may happen due to many conditions which we'll discuss the causes. But how come the exaggerated respiratory responses to CO2 may result in this kind of hyperpnea and hypopnea and apnea? Very simple fact. I told you already, this we have discussed in the high altitude itself, I think high altitude section in the oxygenation basics of the lung itself. But let me tell you once again, recap it. You have a CO2 level which has to be maintained for normal breathing, that is called a CO2 level of 40. This is what we call as a eupneic level. This level of 40 is the one that maintains a normal respiration. That is a normal respiratory rate for a particular individual. And there is a entity called apnea threshold, where the CO2 level, if it reaches less than 32, we call them as apnea threshold. In a patient who is not consciously breathing, remember, in a patient who is not consciously breathing, if the CO2 level goes below 32, the patient is going to stop breathing. That's what we call apnea threshold. But consciously, you can lower the CO2 to 30, 25 also, if you're hyperventilating consciously. But if in a patient who is not consciously breathing on his own, 32 is the fixed set mark level. Below that, if you go, you will not breathe. The system will go for apnea. That is to increase the CO2 levels back to the normal eupneic level. Similarly, I told you, you can hold the breath only up to 50. This is called a breath holding threshold. Beyond this, the drive for respiration will be so high, which will overpower your voluntary control. You cannot breath hold anymore voluntarily. It will break your threshold for breath holding, and immediately you will start breathing and you will hyperventilate. And anyway, your idea is to bring back and maintain your CO2 level of 40 in the body. So this gap between the 32 and 40, which means the apnea threshold and the eupneic threshold, is what we refer to as the CO2 reserve, which means your breathing will be happening between this CO2 threshold only. Clear? If you exceed this CO2 threshold, that eupneic threshold, you are going to result in hyperventilation. If you are going to go away from this eupneic threshold, the more and more you move away from this eupneic threshold in a lower direction, you are going to result in hypopnea. That is hypoventilation. Clear? So this is the idea. So what essentially happens here is, this CO2 level and the respiratory system recognition of the CO2 level becomes exaggerated, which means even if there is a mild shift in CO2 above 41, they will produce severe hyperventilation and they will reduce the CO2 to a near to the apneic threshold. Slowly what will happen is, even if they go suddenly to the little bit lower to the apneic threshold, like maybe 34 or 33 near to the apneic threshold, immediately they will go for severe hypoventilation and they will go for apnea. So this exaggerated responses even to small changes in the CO2 is the main reason for why these patients go for Cheyne-Stokes breathing. So that's what they go for, hyperpnea with a little change in CO2. For example, in this you can understand a small increase in CO2 will cause a dramatic increase in breathing, resulting in hyperventilation. Obviously, this hyperventilation is going to wash out the CO2, and again a small decrease in CO2 will result in severe hypoventilation and complete apnea. And once again, apnea will result in increased CO2 to a small extent, and that will again trigger a lot of hyperventilation, and this cycle will keep on alternating. So this is an exaggerated overshoot as well as an undershoot response to carbon dioxide. That is the reason why you develop a Cheyne-Stokes respiration. This is the typical pathophysiology of why you have this central sleep apnea. Clear? As you understand this, let us see the risk factors for developing a central sleep apnea. The most common risk factor in the world to develop the Cheyne-Stokes breathing and central sleep apnea, I have already mentioned this multiple times, it is heart failure, which is the most common cause and the most common risk factor for CSA, especially the Cheyne-Stokes type of respiration. Second, age more than 65, male sex, and patients who are using opioids, patients who are having CNS disease like a brainstem stroke or a tumor, or some brainstem disease you can write, brainstem stroke or a tumor. Then patients who are living in high altitude, especially in early stages. I told you there is an entity called treatment emergent CSA, which means after initiation of positive airway pressure therapy in a OSA patient. This happens in OSA patient after initiation of PAP, positive airway pressure therapy. Clear? And again we saw the incidence. Incidence is 10%. Risk is more with severe OSA patients and those who are using BPAP than CPAP. Clear? So these are the important risk factors that you have to know. Treatment wise, treatment of this CSA patients is highly controversial because we are discussing only about Cheyne-Stokes here. Other types of CSA, no, we don't want. But Cheyne-Stokes is the most common form. That's what we want to discuss here. How will you treat this central sleep apnea? There are two modes of ventilation. One is a BPAP with a backup respiratory rate. I told you. backup respiratory rate. How this BPAP with the backup respiratory rate will help you? Because you have seen here, the patient is having hypopneic episode, hyperpneic episode as well as apneic episode. So, you know the BPAP is going to give a set inspiratory pressure, which means it will not allow the patient to overshoot also, which means beyond IPAP, your patient cannot shoot. At the same time, because that's the pressure that will stop, beyond that you cannot move. At the same time, it not allow the patient to go for undershoot and hypoventilation also, because you have a set IPAP, which means it will push the breath to that level anyhow. And second thing, this IPAP will prevent this crescendo decrescendo pattern, which means your breathing now will become normal at a set rate, set volume, sorry. At the same time, if they go for apnea, your backup respiratory rate will help. Your backup respiratory rate will kick on and they will produce new breathing and you will not get an apnea. Clear? So this is what the BPAP works. Such a beautiful system is useful for Cheyne-Stokes breathing as well as any patient with a central sleep apnea. Our second option is there, that is called an adaptive servo ventilation, ASV, which you have discussed. This is thought to be very intelligent. If I explain you the mechanism, you can understand. So let us see what is the mechanism of adaptive servo ventilation. This is the mechanism of adaptive servo ventilation, where when the patient is having crescendo type of breathing, you can see when the patient is going for hyperpnea, and all these are prefed. You do a PSG and everything has to be prefixed, and setting of all this machine should be already done before giving to the patient. So that is why they know what the patient, how much the overshoot will happen, how much the undershoot will happen, what will be the apnea period, everything will be understood before itself, before giving these machines to the patient. So here what will happen is, you can see intelligently these machines during hyperpnea, they will reduce the support, and as they go for hypopnea, reduction in the tidal volume, they will increase the support. And during apnea, the backup rate will kick up and they will maintain a constant threshold. Very, very beautiful. Whereas, what is the difference between BPAP is, BPAP, the curves will be like this only. Irrespective of what hypoventilation or hyperventilation or backup respiratory rate, they will maintain at a constant IPAP. There won't be any change at all. But here, you can clearly see the IPAP will keep on changing intelligently, depending on the respiratory responses of the patient. If the patient is taking a low breath, there will be more IPAP that will kick in and they will produce a set ratio. And if the patient is taking more breath, the IPAP will reduce and they'll give a very small support only. So this is very intelligent. And during the apnea period, they'll go for a backup respiratory rate and that will kick in and they'll produce a constant IPAP. So here the IPAP is labile and fluctuating. That is what we call it as adaptive servo ventilation, which adapts to the patient's breathing type. So at the moment, like when you look at it, it looks very intelligent and it also looks very promising, but it is not reproduced in the trials. That's the idea. Some recent trials that too have shown excess mortality in patients who are having heart failure. Excess mortality in heart failure patients with adaptive servo ventilation. So, but this needs confirmation, even though this is the very preliminary trial data, but this needs confirmation. But right now, adaptive servo ventilation, even though it looks very intelligent and promising, it is not followed in the regular practice. We use BPAP with backup respiratory rate. That's all. This is the treatment of choice as a final verdict for patients who are having central sleep apnea or Cheyne-Stokes respiration. That's all. Clear? Then final topic that we are going to discuss is on the obesity hypoventilation syndrome. Obesity hypoventilation syndrome, that is otherwise referred to as Pickwickian syndrome. Pickwickian syndrome, which means obese patients themselves tend to hypoventilate a lot. So what is the evidence of hypoventilation? That's why we have the diagnostic criteria for this, very important for exams, where the patient should have a BMI of more than 30, which means BMI of more than 30 is what we call it as obesity. 25 to 30, we just call it as overweight only. That's why it's called obesity hypoventilation. That's why BMI should be more than 30 in the first place. Then patients daytime PCO2, which means even during the day, not see in the nighttime PCO2 elevating is common in OSA. Because of obstruction they are going. In the night they don't breathe at all. How you expect the CO2 to be normal? But in these patients, the daytime PCO2 itself will be more than 45 millimeters of mercury. Which means in the daytime itself they are having hypoventilation, not only during the night, like OSA patients. Then You have to rule out other causes of hypoventilation, which means patient is not having any neuromuscular or any other cause of hypoventilation. Hypoventilation. Clear? So these are the 3 diagnostic criteria. This should be there to diagnose Pickwickien syndrome. And if you do a PSG in these patients, what will you find out? PSG in these patients, if you will find out that 90% of the patients will have associated OSA. They will have associated OSA. 90% of the patients, surely. And only 10% of the patients, but still significant, 1 in 10 will have only this Pickwickien syndrome without any associated OSA. Which means this syndrome can happen alone also without associated OSA. Clear? You might expect all obesity means they should have only OSA definitely for sure. Not like that. 10% of the patients may have only this obesity hypoventilation syndrome without your background OSA at all. Fine. So what is the pathophysiology? Why they go for hypoventilation even during daytime? All the time they are hypoventilating. Their breath is not sufficient. Why? Are they having any neuromuscular paralysis? No, they don't have any neuromuscular problem. But let us see the pathophysiology. Number 1 is the mechanical load on the lungs. Because obese patients' tissues are so heavy that they compress their own lung. That's a mechanical load. Number 1. So they cannot expand the lungs to the full capacity. VC will be reduced a little bit, looking like an RLD, but your total lung capacity and all will be completely alright. But they will be breathing a little bit less compared to the normal patient because of the serious mechanical load of fat that is compressing on their lungs. Fine. Second one, these patients will have blunting of chemoreceptor reflex. And because of that, they will have reduced ventilated drive itself. So all these things will contribute to the pathophysiology in these patients. How you are going to treat? The most important is going to be weight reduction. Weight reduction is the most important thing. At the same time, you can supplement them with positive airway pressure therapy. Remember, the mechanical load on the lungs is the most important. That is the reason why they are going for this hypoventilation. So the weight reduction forms the major and the most important treatment in these patients than a positive pressure therapy. Weight reduction is the gold standard here. But if you want to give a positive airway pressure therapy, it's better to prefer a BPAP with a backup respiratory rate. Why BPAP? Because I told you the moment you call the word hypoventilation, you have to use BPAP only. You cannot use CPAP. CPAP will not help you in hypoventilation. Don't worry about it. Even if you open the airways, doesn't matter. The CPAP, if you give, it might be useful for the OSA, but it will not deal with the hypoventilation component. Hypoventilation component can be treated only with the help of BPAP. Clear? With or without a backup respirator. But definitely any BPAP you give, they will have a backup respirator, so no problem. If you have a central component also, no need to worry. Everything will be clear. So these are the important things I want to tell, especially the criteria. Don't forget, this is a multiple times asked question in exams. What are the criteria for diagnosing Pickwickien syndrome? Clear? So I think we have discussed in detail and we have very good coverage on the OSA, CSA and Pickwickien syndrome aspects. These are the most important questions. Everything, all the details I have discussed. So with this, we will complete this particular section and we'll move on to the more important section and very big section we are opening up in the form of ILD in the next video.